Thank you, Susan. I'm very thankful to the Sanibel Planning Committee for asking me to be here, and also very thankful to the committee and the task force that helped develop and put a lot of time into these guidelines. So I'm very excited to share these with you today. To start with, I have no disclosures. And this is actually a really tragic incident that occurred back in 2005. And this was a patient that was placed on cardiopulmonary bypass, and inadvertently the perfusionist had added too much calcium to the prime. The patient unfortunately suffered irreversible neurologic damage. And a lot of things truly came from this event. And ironically, we actually had one of the surgeons that recently visited our hospital and was talking through some of this public reporting and the different STAR systems for congenital heart surgery, but was actually alluding to this time and how this really was at their institution. And apparently, the public was just outraged by this incident, very understandably so. But he was saying that people were picketing along the walkway into the hospital. So, every morning coming into work, knowing that people really think that you're doing poor quality care for patients. And unfortunately, in this incident, led to the death of a child. What came from this was 2 years following was what was known as the Gritton Report. This was written by a former NHS director named Mark Gritton. It was a 53-page document that was outlining the resultant investigation into that specific incident, but also looking more globally into perfusion practices. You can see on the screen there some of the outcomes from their root cause analysis were looking at the fact that this was an infrequent procedure, that it was resulting from inadvertent human error, and that it really was a true perfusion system failure at a national as well as a local level. They also investigated staffing issues that resulted in this incident for this, unfortunately, for this patient. Some specific recommendations that came out of this were looking at perfusion practice regulation, so standardization and decreasing variability amongst perfusionists nationally. Also a staffing review, looking more into what is adequate staffing and how many perfusionists should we have for different cases or different complexities. Additionally, training and team development. So really, how do we, what they were essentially alluding to that we, commonly report to now is simulation, and how do we drill these things as a team? And then finally, looking at protocols. Protocols were a really, really big part of this, and at an institutional level, how we standardize our practice. After this, the Department of Health published this, what there is known as the Guide to Good Practice in Clinical Perfusion. This was really a call for societies to publish documents that allowed for good clinical practice for perfusionists. Again, promoting standardization and as a guide for patient safety. This paper was actually published in the Becker Health Review, and it talks specifically to the variation in healthcare delivery and our continued need for standardization. We see outside of healthcare and other industries, including automotive, nuclear, even aerospace, where they respond to major safety crises by standardizing their processes and ensuring that there's consistency among this workforce. It's resulted in a level of uniformity that's allowed these industries to perform their job functions with fewer incidents and better overall results. So this looks specifically at the variations, and it talks about how it's truly problematic for multiple reasons, and it may lead to decreased patient safety and heightened confusion for both the patient and the physician. And you can see the second part here is really acknowledging how difficult healthcare standardization really is, and that it is needed, but the argument ends up coming down to who does it the right way, which is where we really need evidence-based practice to continue to drive our profession forward, and is really a call to us all to contribute to this. Some other bodies that are really working on standardizing our practice as healthcare professionals. One specific to pediatrics is called the NPC-QIC, and this stands for the National Pediatric Cardiology Quality Improvement Collaborative. And this is a group started primarily as cardiologists looking at specifically hypoplastic left heart syndrome and the variation in management, the variation in time between our interstage repairs, and then even diving deeper into specifically the different stage repairs and how we're managing them, anticoagulation management, and surgical repairs. And why some centers have patients that, fly through these operations and do really well, where there's overall nationally some of these stages where we all struggle with the best care to provide for these patients. So this has been a well-established collaborative that has been, going on for a long time, and looking at now down to, some more specific and minor details on how we manage these patients. There's actually now a perfusion component to this as well, but again, is another large body that's really trying to improve the care that we provide for our patients, as well as standardizing this across the nation. Another organization that is a little bit more specific is the ACTION Network. And ACTION stands for the Advanced Cardiac Therapies Improving Outcomes Network. This is a little bit more specific to VADS and heart failure management for patients. But this is another incredible collaboration where there's data sharing as well as protocol sharing, and trying to come up with some truly national standards on how to manage these patients. And I think, 10 years ago, or, even farther back, we would probably have argued that, there's just no way to get everyone on the same page on how we're going to manage anticoagulation, on ECMO or a VAD. And this group has really embarked on that challenge and has come up with some universal evidence-based protocols that a lot of centers are now participating in and saying, we will standardize our care and we will follow these protocols. So that ultimately we can have a better, truly multi-institutional data collection, and a way to see which practices really are better at providing better outcomes for our patients. Another approach that a lot of you may be familiar with is the ERAS, so the Enhanced Recovery After Surgery. So really looking at using evidence-based care models and standardizing practice to help with these adult cardiac patients. And this group has found that they're following their protocols in major surgery has reduced recovery times and length of stay by 2 to 3 days, and complications by 30 to 50%. So I think this really speaks to how this can truly have a large impact on the safety we provide our patients. Moving a little more close to home is specific to AmSEC. So looking at our perfusion resources that are available to us. AmSEC does have a wide variety of resources that are available on the website. And since 2011, AmSEC has developed documents for both cardiopulmonary bypass as well as mechanical support. And most recently, in 2019, the Pediatric and Congenital Standards and Guidelines were approved through AmSEC. In addition to this, there are a number of other selected clinical topics, such as anticoagulation, temperature management, inflammatory response, as well as blood conservation. And you can see many of these are endorsed by surgical and anesthesia societies. In addition to our AmSEC resources, there are also international resources, which I know that you heard from Luke yesterday about some of the standards and guidelines that they have developed. There's also documents from Great Britain and Ireland, the Netherlands, as well as the Brazilian standards and guidelines. And something specific in one of these statements is that it says, because one size does not fit all, the need for a standalone standards and guidelines document to perform perfusion for congenital heart surgery is unquestionable, and it will in many ways be unique as compared to the ones used for the correction of acquired heart disease in adults. And something that we, when we embarked on this journey, really wanted to make sure that we understood, is there a need for a specific separate document for pediatrics, or is the adult document something that we should follow on a national basis? So this process started about 3 years ago. Myself and three other committee members that are on the AmSECT Pediatric and Congenital Committee, we went through the adult document line by line, and we first looked for topics that weren't applicable. And again, we found very few topics that we didn't think that were in the adult document that also applied to pediatrics. We then created a draft that incorporated everything that we felt was important specifically to pediatric perfusion, and then followed through with literature review to support what our recommendations were as a committee. We then invited commentary from the following groups of perfusionists. So we started with the larger committee, so our Pediatric and Congenital Committee. We then sent this out to the Fellow of Pediatric Perfusion. So there's about 110 members, and this is something that is through AmSECT and is an application process that has a requirement of ongoing education, commitment to congenital and pediatric perfusion, as well as requirements for caseload. So it's evidence that you are practicing pediatric perfusion, as well as a weight-based component to show that you are participating in neonatal and smaller birth weight patient repairs as well. So this was the group that we really wanted to make sure that we were trying to get this document to as many people as possible to get input, as well as consensus, as well as our committee consisted of 8 to 10 people, as well as, the 4 of us trying to do the legwork for this. But we wanted to make sure that this truly represented nationally what pediatric perfusionists felt was important, which is why we then went to the Fellows of Pediatric Perfusion as our second group to allow for commentary as well as survey results. We then took the edits and the draft from that and worked with the ICEBP. They were an integral part in the adult generation of their standards and guidelines, and we also highly respect their knowledge of the literature and truly, vetting out the evidence-based practices that we wanted to push forward. Then lastly, we sent this to the AmSEC Board of Directors as well as their legal team. And the purpose of mentioning these various groups that we have sent this to and asked for feedback is really to show that this was not for perfusionists or a small committee that is trying to make decisions on what we think is important in pediatric perfusion, but that this information has truly been vetted by the largest part of our community, and was something that we wanted to make sure and we felt was very, very important in inclusion on this moving forward. A quick disclaimer, we do realize that there are statements in here that are standards or guidelines, and they really have an impact on capital expenses. I'll talk in a little bit about some survey results and some struggles that we've had, specifically at my institution. But we realize that every department has a very different budget structure as well as reporting structure, where you're able to or not able to really fight for different things that we need from a capital standpoint. So we do realize that this does have an impact on that, as well as some of these suggestions are outside of the scope of a perfusionist. And at times we are limited when we have a surgeon or anesthesiologist that have very firm beliefs on the practices. We realize that we are limited because we do operate under them. The goal of this, ultimately, any of these documents that we are creating are a resource based on clinical evidence and currently accepted practices. The early efforts were based more on surveys and individual experience or society endorsements, whereas now we are really trying to move our focus more towards evidence-based practices. And as stated on the AmSEC's website, these documents are intended to serve as a useful guide for teams in developing institutional specific protocols to improve the reliability, the safety, and effectiveness of extracorporeal support devices. And obviously, as we continue to develop these resources, it's really to continue to drive our profession forward, as well as to be leveraged to drive quality assurance and improvement in our departments, as well as ultimately improve safety for our patients. The need for a separate document specific to pediatrics has really been a goal of the Pediatric Committee, as dated as far back as this paper, which was published in 1998, Scott Lawson and Ed Darling. And they stated in their paper that to date, there are no guidelines that are available to direct the practicing pediatric perfusionist toward a more successful pediatric practice. AmSECT has formed the Pediatric Committee, which coordinates continuing education seminars and facilitates communication within the pediatric perfusion community. But the development of guidelines is stated as one of the Pediatric Committee's goals. This is the adult document that was accepted and voted on by membership. And then this is a subsequent document for the Pediatric and Congenital Perfusion Practice. You'll see highlighted on the screen there 3 different standards that we're going to talk about a little bit more specifically, but those were the bigger components that were added to this document. And a quick terminology review for those of you who don't necessarily read this type of terminology. To start with, a standard is something that is considered a minimum requirement for cardiopulmonary bypass. A guideline is used as something that is for the assistance of the development and implementation of protocols. A protocol is looking at something that is specific to your institution as a written document that is used to guide your practice at your hospital. The word shall represents a mandatory requirement, and the word should is a recommendation. So when we get a little bit more specific into these, and to summarize our modifications, we did generate 3 new sections. So the first is circuitry, priming, and fluid balance, and we'll go over those in a little bit more detail on the next slides, as well as 11 new standards and guidelines and 5 guidelines that were elevated to standards. So looking specifically at the new sections, Standard 13 is looking at priming. This is looking specifically at the impact of the smaller patient blood volume in a pediatric or neonatal patients compared to the ratio of priming. And you'll see in the graph up here, just trying to show a relationship. So the darker blue is showing the patient prime volume, and then the lighter blue is looking at the circuit volume. So you can see that in the neonatal or pediatric population, at times we're entirely replacing their blood volume with a prime volume. And what specifically we wanted to make sure that perfusionists were looking at were the electrolyte levels, as well as the COP, so the colloidal osmotic pressure, as well as coagulation. And perhaps in the case study that was mentioned in the beginning of this talk, this specific level of standards and guidelines may have been a potential way to prevent or even catch that accidental excessive use of calcium in the prime, and ultimately the death of the child by running and managing and monitoring these electrolyte levels in the prime gas. The subcomponent of this is that a circuit prime gas shall be obtained. So knowing that there are times where coagulation is impactful based on whether or not you have blood or FFP in the prime components, this circuit prime gas becomes very important. The second part, which is a guideline, was looking at pre-bypass ultrafiltration. So there's evidence that supports both techniques, whether it be pre-bypass ultrafiltration, so pre-buff, or washing the red cells in a cell saver prior to putting them into the circuit. There is additional need for a higher level of evidence to really run those 2 techniques head-to-head to really say which one is better or if there is a superior technique. However, there is literature that supports both of them, which is why we felt that it needed to be a guideline and that both techniques were in there for management. Also, again, back to the ratio of prime versus the blood volume. patients that may be hyponatremic or have other baseline electrolyte imbalances. It's important to make sure that you're matching the prime composition for those specific patient values. Then moving to the second additional standard, which is fluid management. So the standard states that fluid balance shall be monitored continually and documented throughout cardiopulmonary bypass. There's definitely literature that correlates a positive fluid balance with mortality as well as a negative fluid balance. So again, this is why we're suggesting that it be continually monitored. So looking at this first paper, some of the literature to support that standard was published. It's called The Correlation of Fluid Balance Changes During Cardiopulmonary Bypass to Mortality in Pediatric and Congenital Heart Surgery Patients. This study was a retrospective single-center study, and their primary outcome was truly looking at mortality. And they concluded that a positive fluid balance as well as excessively negative fluid balance is correlated to different degrees across different subgroup comparisons to higher mortalities. Again, this is looking at the fluid balance only on bypass, so not considering total fluid balance during cardiac surgery or during their length of stay. This is looking specifically at bypass. And their conclusions were also that the fluid balance needs to be monitored by the perfusionist. An additional paper that was published called Highly Positive Intraoperative Fluid Balance During Cardiac Surgery is Associated with Adverse Outcomes. This was an adult study, a single center study, as well as a retrospective study design. This looks at the fluid balance throughout the entire intraoperative course and was associated with increased length of stay and the need for transfusion on patients with fluid balance that is greater than 500 mLs. So this is also strongly supportive of the guideline of monitoring fluid balance in general, although this was, again, an adult study. This third study that we used to justify that standard of fluid balance was this study looking at fluid overload and its association with higher mortality and morbidity. And again, this was a retrospective study that included 1,500 pediatric patients, so under the age of 18. Their eyes and nose were recorded for 72 hours postoperatively, and patients with a higher fluid overload had more complex surgery, were younger and smaller. And they found that early post-op fluid overload was independently associated with worse outcomes. And so we're not sure that this is a direct correlation with this, but is certainly relevant to pediatric cardiac surgery and fluid management. The addition of MUF as a guideline versus a standard has been controversial for a few reasons. The literature is not unanimous in its support. And there's a lot of talk in the pediatric community about a trend away from its use. However, based on a 2017 survey, which hopefully is going to be getting submitted for publication soon, this is a pediatric perfusion survey, and you'll see that on the x-axis are the different types of MUF, as well as the y-axis shows the percentage. But you can see here that there is still a large majority of the population that does perform MUF on their patients. Again, domestic is about 71% and the international is 76%. Guidelines that were increased to standards. The first one is 7.6, so continuous blood gas monitoring. We really felt that it was important that as we're fine-tuning blood gases as well as the large fluctuations in temperature, that this was really important to notify you as there is an issue, as well as the safety for patients. This was also supported by a survey that was conducted in 2011, as well as the 2017 preliminary results support this. And you can see that pediatric perfusionists, there is a vast majority of patient or of centers that use continuous blood gas monitoring for every single patient. The N+1 was also another example of a guideline that was elevated to a standard. And this was perhaps a more controversial topic in addition to the MUF content. But we do know that from the literature that in pediatrics, the rate of incidence is 2 times that of adults. And it, again, provides more of a reason to have 2 people per case on some of these more complex cases. We also decided this based on consensus as well as the community-based survey data as well. A couple of the new standards and guidelines. So one is 6.3, so utilizing a cardioplegia bubble detector. And this is stating that a gross or a macro bubble detector should be used to control the cardioplegia pump, as well as to allow for the interruption or modification of the muff flow. With different circuit configurations and ways to muff, we accept the fact that muff is an incredibly difficult or not difficult, but risk for a patient with the increased negative pressures that are exacerbated on the cardioplegia circuit. And utilization of a bubble detector was incredibly important, as well as for the safety of patients. The additional use of supplemental CO2, again, to avoid hypocarbia in these patients, as well as the different equipment that can be used. A microregulator will increase the safety for patients, as well as the utilization of pH stat blood gas management. So most recently in 2020, we conducted a survey again to the fellow pediatric perfusionists, just to look at the adoption and to see, since the vote and the acceptance of membership, to see how this is really impacting our community. So the first question we asked is, are you aware of AmSEC Standards and Guidelines for Pediatric and Congenital Perfusion Practice? You'll see that majority of respondents said that they are, almost 90% said that they are aware of these standards and guidelines. We then wanted to assess the dispersion of this outside of just your pediatric or outside of your perfusion team. So then we wanted to assess whether or not the surgeons and the anesthesiologists on your team are aware of these guidelines. And 65% said yes, and 35% said no. So you can see that we still have work for distribution outside of our perfusion community and getting the buy-in and the support from anesthesiologists and surgeons as well. We then asked if has your institution adopted any changes in practice due to the release of these standards and guidelines, and 62.5% said that they have, and 37.5% said that they have not. So we wanted to look a little bit deeper into that question and understand what are the things that people are able to implement. And you'll see the bullet points on the screen, but looking at blood gas monitoring, somatic as well as cerebral oximetry monitoring, supplemental CO2. The interesting and overwhelming response was really about staffing. So you'll see that it says staffing increased. So 3 people made a comment that they were able to increase their staffing due to this, as well as on the other column, you'll see the N+1. So people kind of responded to those differently, whether it be a staffing or N+1, still talking about the same topic of guideline. But you'll see that there were 5 more people that were able to add staffing to this. And anecdotally, that has been something from different meetings and just talking to different communities. It sounds like that has been something that has been really helpful for people to go to administration to get additional staff for their perfusion department. Stopping suckers at the start of protamine, and I kind of giggle with this. This is something that we have struggled with at our institution. And, as we talk through these standards and guidelines and talking about budgets and costs and just different hurdles that we have, I think, every institution has different hurdles, and it's a matter of, there's some people that are on, one end of the spectrum where, you're going to struggle with the monetary piece and trying to get equipment and support from administration standpoint. And then there's other centers that are going to have, a lot of support and have surgeons that immediately buy into the concept of perfusion standards and guidelines that are excited about it. And then there's the rest of us that are probably somewhere in between, where we're able to use this document to support some of the things that we have felt are important as perfusionists. And then there's still going to be challenges and hurdles as we move forward with this document. Again, which is why a big challenge was finding evidence to support these practices, and that really calls to us as clinicians to really come out with these studies that are going to support the practices that we all do every day. Implementation of MUF. So one person commented that they were actually able to reinstitute MUF at their institution due to this document, as well as checklists. So going on bypass checklists, they were able to justify this practice and safety guideline for their group. We then asked, do you think that developing these guidelines is a benefit? So again, you'll see that almost 90% of perfusionists said that this was helpful, which again is a lot of support for the amount of time and work that went into creating this document, but also motivation moving forward to continue to update these to keep them in line with current trends in evidence that is being published. We then wanted to understand if your institution is not using AmSEC standards and guidelines, are you using another standard and guideline? So you'll see that there's another 20% of respondents that said they were using another document. The most alarming thing to me is that there's still almost a quarter percent of our community that's saying that they're not using anything. So we're not using the documents that AmSEC's providing, or guidelines that might be outside of AmSEC, whether it be anesthesia or surgical guidelines that your team is following. There's still a large percent that are not using this to implement that. So this is something that we, as a committee, want to look into further and better understand why the adoption isn't there, and what we can do as a committee to provide sound, documents and support for our community. We then asked what things they were unable. So if there's a specific standard and guideline that they're unable to implement at their institution, some people were saying the N+1 because of budget, as well as just staffing concerns, that they were unable to provide the additional staffing, even with the use of the documents. Another comment was about flow probes. So they were unable to add flow probes to their practice, and due to manufacturer limitations. And I think this, again, calls out another important thing, is the relationship with clinicians and manufacturers. I think this is really an important time for us to be involved in the future developments, as well as giving valuable feedback to our industry partners to understand what we are trying to do on the front lines as clinicians, and what we need the devices to, how we need them to perform for us to do our job better and safely. The suckers off with protamine made me smile, because there's somebody else out there that's struggling with this component as well. And the feedback was that there was resistance from their surgeon. Another comment was that they were not able to implement some of these standards and guidelines is because they weren't endorsed outside of AmSECT. And this is something that we are currently underway, and I'm very excited to say we have a draft that is being passed around currently. Is a manuscript, and we are working with the Congenital Heart Surgeon Society to publish this document, and hopefully engage their support from their society endorsing this and giving further justification to these practices. And lastly, I wanted to share a quote with you from one of the feedback from the surveys. It says, the Pediatric Standards and Guidelines gave me all I needed to justify another FTE. Administration understood the gap when someone was on vacation. We discussed all options and fully supported the new position. These standards give perfusionists leverage, since most individuals in administration may not be aware of what we do every day. Developing these guidelines specifically for pediatrics holds more weight. And lastly, are some of the challenges that we faced in trying to develop these. So this was not necessarily an easy task, and we have been faced with challenges and limitations as far as what we can require or really recommend from programs. First is that we know that we are lacking strong evidence. While it's ideal to have a completely evidence-based practice for everything that we recommend or that we do as a community, we know that the literature is just not there yet. And again, this is a call to all of us clinicians to really start providing this and working on these things as institutions and across institutions. Secondly, we know that ultimately our practices are approved by surgeons. So it might be difficult, for example, to recommend modified ultrafiltration as a standard when some surgeons just have a very strong stance that that is not what they want as part of their practice. We also know that some centers are or might be limited by the equipment or resources. They might not be able to meet some of the minimum requirements for staffing. However, we do feel this is incredibly important to have this document as a way for those to advocate for those missing things in your programs. And whether it's equipment or staff members, if the evidence, as well as the majority of pediatric perfusionists feel that they're important, then this is something that should be strongly considered. And finally, there's always a struggle for consensus. There's a large variety of practice when we look at this nationally. And even when we look inside of our own centers, I think we could all probably say that if you have a program with 6 perfusionists, there are probably 6 different ways of doing things. And as a community and as a larger scale, as we begin to implement and embrace these quality tools, as well as projects within our departments, I know specifically for us, we are working on reducing variability. So we look at our data monthly and 3 primary different outcomes. And we look at them as a group, as a team, how we're doing on compliance with what we agreed on as a team was a normal range of operation. And then we look at it more specifically by perfusionist. And then, we say, perfusionist 1 has great compliance with this component that we as a team, vetted the literature and thought this was the best practice for our patients. So what is perfusionist A doing that the other perfusion group isn't doing that we're not getting as good of compliance? And then we can learn from each other. And really opens that door for a culture of learning and embracing really how we can learn from each other and grow as a profession. So in summary, looking back, we truly weren't sure if a document like this was even necessary. All patients, we believe, should receive the best quality of care. But in developing this, we really broke down the differences between the 2 patient populations. And a lot of our recommendations revolve around the precision of care and truly unique considerations specific to congenital perfusion. We really hope that this will be a resource for all perfusionists, new programs, our international colleagues, as well as outside of our perfusion, just outside of our discipline. Once this is published, we really hope the centers in the U.S. will review their own policies and procedures and protocols and really try to implement these things on a state and local level. And finally, the purpose of this document as a profession is really just to say what we do and then ultimately follow through with it and to do what we say and later work on improving our practice and improving our safety and outcomes for our patients. I thank you for your time today, and also a huge thank you to Molly Oldine. She put a lot of time and effort into keeping our task force together, as well as helping with the preparation of this talk. Thank you so much for your time this morning.